Morning, everyone. Thank you for coming to our June edition of the Global Surgery Grand Rounds. A little bit of housekeeping before we get started. We have our speaker who will be speaking to us for about 35 minutes. I'll introduce him in just a second. And then we'll have time at the end for Q&A. There should be at the bottom of your screen a Q&A button to type in questions. So if you have questions as they come up as Professor Ataguba is speaking, please do use that. So without further ado, let me introduce our speaker for today. Professor John Ataguba is an economist who has interests in health financing, health inequality, social determinants of health, as well as methodology design and the economics of aging. He's an associate professor and the director of the Health Economics Unit at the University of Cape Town. He is also a deputy director of the African Health Economics and Policy Association. He's a member of the board of directors for the International Health Economics Association, and also a member of the World Economic Forum's Global Future Council for Healthy Aging and Longevity. He's received many awards, including the T.W. Kambuli NSTF Award for Emerging Researchers in South Africa and a Mellon Mandela Fellowship at Harvard in 2016 and 2017. And without further ado then, John, over to you. Thanks for being here.
Good afternoon, good morning, good day, depending on where you are. Thank you so much, Mark, for the very warm introduction. And it's a pleasure to be here to talk basically colleagues through this work that I've done quite a while ago, and it's still ongoing, it's still work in progress. Okay, it's basically about a novel index to be able to assess coverage with health services, focusing particularly at antenatal care in this case. If you're interested in knowing more about what I'm going to present, you're happy to take a snapshot of this, or I would as well share this if you want to, if you indicate. So it's about finding ways to reassess coverage with antenatal care in such a way that leaves no one behind and captures the use of health services across the whole spectrum. Though I'm an economist, but what I'm going to present today, it's not economics per se, it just cuts across many things, which you will see in a while. I will try to skip those that are heavily focused on economic methods as much as I can. So just to kickstart, you would, in terms of overview of the presentation, you would have a motivation. Why did I even come up with this in the first place? And we'll try to give an overview of key issues that you need to be aware of, and also the objectives of what we're doing, and look at the methods for reassessing coverage with ANC services. Thereafter, we'll have an empirical application using Uganda, which is one of the countries in sub-Saharan Africa, and we conclude. So let's go to motivation. We kind of know that the access to antenatal care services for pregnant women is a global concern, especially within developing countries. We have the case where many developing countries do not have a very sufficient uptake of antenatal care coverage. And there are many reasons behind that. You can find countries with less than 50%, up to just 30% of pregnant women having at least 4 ANC visits, which is very dismal, if you understand that statistic. And we know that antenatal care coverage is really an important care for pregnant women because it's a point of contact between the pregnant woman and the health facility. And it's a time when you can pick up any complications in pregnancies, and also to provide guidance to women, especially first-time mothers, on the journey, the experience of pregnancy. The SDGs talk a lot about good health and well-being, SDG number 3, amidst many other SDGs. And within that, there are key indicators, one targeting maternal mortality, and then the other one neonates. And the goal is to reduce maternal mortality and neonates deaths amongst neonatal deaths significantly, and more especially in developing countries. We know that one way to address this is through antenatal care service, antenatal care, but it's not all about antenatal care, but it's really an important part of that journey. There is also a bigger picture of the so-called social determinants of health that we need to look at. But apart from the social determinants of health, antenatal care is a very important point of contact there. And antenatal care was an indicator for the MDGs that just passed, and of course, kind of implicitly within the SDGs. A quick snapshot of some of these statistics in selected African countries. We find that maternal mortality ratio is really, really high in many African countries. It can be as high as 210, or global average of about 210 maternal deaths per 100,000 live births. But if you look at countries like South Sudan, you see there Chad, Sierra Leone, Nigeria. These are global leaders in something that is not good, which is maternal deaths. You find ratios in excess of 1,000 deaths per 100,000 live births, which is very, very problematic. Again, when you move to neonatal mortality, again, you find that the countries I listed earlier, especially Nigeria, is still featuring. Again, South Sudan is still featuring. These are leaders in terms of neonatal deaths, even though the global average is sitting at below 18 deaths per 1,000 live births. So what then? What about ANC visits? If we just zoom in on ANC visits. Prior to 2016, the WHO had, in terms of recommendations for ANC services, had a recommendation that pregnant women should have at least 4 ANC visits, especially for uncomplicated pregnancies. But when pregnancies are complicated, there is no limit. The limit is determined by the complications. But for uncomplicated pregnancies that make up the bulk of pregnancies, WHO recommends at least 4 ANC visits. But from 2016, it was revised to having at least 8 contacts, not visits. Contact in the sense that you could have come to a health provider for something else, but because you're pregnant, it will be, of course, part of what will be examined as well. And there is, of course, a very positive relationship between having ANC visits and also many other indicators, health indicators. Even though WHO talked about having at least 4 ANC visits, they tried to augment that with having 1 ANC visit. So you have 2 things, having at least 4 ANC visits or having at least 1 ANC visit. But that's how far you go. It's like a switch. If countries have put in substantial amounts of money in moving people from having 2 ANC visits to 3 ANC visits, such countries don't count. The only country that will count is the country that has been able to move people to at least 4 ANC visits. So it doesn't really fit within the move towards universal health coverage in the context of progressive realization. And that's where this research comes in. So this is the schedule for the WHO's recommendation from 2016 onwards in terms of spacing contacts with health service providers. Why then do we need ANC visits index to be revised? I tried to allude to this a while ago, but we know that if you have at least 4 ANC visits, it's not really sensitive to policies that have kind of increased the proportion of women who've attained 2-3 visits. So if a country had 100% of women with no visits and puts in a lot of money and move 99% of pregnant women to at least 3 ANC visits, you find that that country may not count fully as a country that has moved people into 4+ visits. But that's problematic because those investments are really worth seeing outcome from it. So the notion of progressive realization is very important in this context. We want to see how countries move their populations from a 0 base progressively till you hit whatever the policy objective might be. It could be 4 contacts, 4 visits, 8 contacts, but whatever the policy objective. But let's monitor how countries move progressively. We can't monitor that using ANC 4 visits as an indicator. And also the old indicators, indexes in account for quality. That's again another big problem. So the paper basically develops a simple index, very simple in the sense that it can be computed easily, that we can use to assess ANC coverage, looking at the entire spectrum, not just looking at least 4 ANC visits, but from 0 to whatever we want to, wherever we want to end. And I try to extend the index to be able to account for quality of ANC services. So it's not just having 4 visits, but what is the quality of each visit? The model is able to account for that as well. So let me illustrate this in a very, very simple language. So imagine we have that box you see there. The box basically has two, one is shaded, one is unshaded. The unshaded portion basically gives us an indication of coverage. So what this tells us is, imagine in this country, about 38% of pregnant women have had at least 4 ANC visits. So if you start from the left, you see it's about, roughly speaking, 35, 38, let's just say 38. 38% of pregnant women have attained at least 4 ANC visits. And if you move to the proportion that have at least 3 ANC visits, it goes as high as about 58%. So it means whilst 58% of the population, pregnant women in this country, hypothetical country, has attained at least 3 ANC visits, only about 38% had 4 visits and above. Again, if you want to look at women who've had at least 2 ANC visits, and that jumps up to about 65 or 68%, and then it continues that way. So if you take a quick look at that, it tells us that the proportion of women who've had no visits can be inferred directly from there to be roughly at about 15%, basically, of pregnant women in this hypothetical example. So what this index tries to measure is, the index tries to measure what is the share of the unshaded portion in the entire rectangle you see there. So that portion of the unshaded portion gives us the value of the index. That ratio is basically the value of the new index that I'm proposing. And the whole idea behind the index is to, as much as possible, minimize that gap. So as soon as you add more ANC visits, you notice that the gap is being shrunk. So you try as much as possible to minimize the gap by maximizing coverage. So if you maximize coverage, you minimize the gap. And by implication, the sum of the two indices will be equal to 1, because the indicator and the gap would sum up to 1. So the whole idea behind policy is to maximize that B, the area B, as much as possible, and minimize the area A as much as possible. And anything you do, whether you increase at least 1 visit, at least 2 visits, at least 3 visits, if you quickly take a look, you see that that gap will be minimized. So anywhere you come to it, you will definitely minimize that gap, which you don't capture if you use the previous methods. Great. So let me give a quick illustration here. Just follow me quickly. You would notice here how interesting this can become. So this is a case of a country. I've just chose 4 hypothetical countries. Now, in each of these countries, at least in terms of women who've had at least 4 ANC visits, it's 49%. So 49% of women in these 4 countries have at least 4 ANC visits before delivery. But if you take a look, you would quickly see that all the panels, even though the proportion of women who've had at least 4 ANC visits is 49%, one country is, hypothetical country, is better than another hypothetical country. In this case, you would see quickly that ANC coverage in all the panels are not the same, like I said. And the question therefore is there any reason to believe that coverage rate in panel A is worse or better than B or C or D? You would quickly notice from what I gave you earlier in terms of minimizing the gap, that one has the largest gap and one has the minimum gap, whatever that means. So you would see basically that for panel A, the coverage indicator is about 0.87. But if you move to panel C, it's 0.49. And the reason is because in panel C, 49% of pregnant women had at least 4 ANC visits. The rest had no visits. Okay, but if you report the statistic, the 4 countries should be the same if you use the old index. But if you decide to use the revised index, you'll be able to capture the fact that some countries have made tremendous progress, even though the proportion of pregnant women who've had at least 4 ANC visits still stands at 49%, but some countries have progressed further than the others. And that is very important to recognize. And it really matters in this case for policy, because we really need to know then how to move people from a low base to a higher base. Now, the question is, who will be left behind? You will see in a while, when I show you the case of the empirical assessment, that unfortunately, the poor will be left behind if we decide to keep using the old indicator. Reason being that the poor folks are those that tend to have fewer visits. So if you try to increase the visit among the poor, you will never capture progress until you get to a point where you have at least 4 ANC visits, which is the domain of the rich. So progress amongst the poor will never be captured if you continue to use the at least 4 ANC visits. But at least we can capture progress amongst the poor if you move away from that using the new index. So basically, this tells us that in terms of panel A, it's about 87, panel B to 72, well, not percent, 0.87, 0.72, 0.49, and then 0.62. But clearly, we know that panel A is preferred to panel B, and panel B is preferred to panel D, and the worst of them all is panel C. And of course, by implication, A is the better one, is the best here. Increasing ANC coverage among women with fewer ANC visits is therefore missed if we continue to use the previous way of assessing coverage. And you should know why that is the case now, basically. Now, the proposed index, I will show this. I'm not going into this. I'll try to be fast here. If you're interested, for those who will be mathematically inclined or statistically inclined, you might want to quickly take a look at it. But this is one way of computing the index. I put in the paper 2 ways of computing the index. There might be maybe many other ways. Then the other way, which I think is simpler, is the alternative computation I put here. The problem with the alternative computation is that you will not be able to capture quality, which you will if you decide to use this method. So it's a matter of choice. Again, whichever method you use, you get the same result for the gap as well as the coverage. And how do you interpret the result, whatever result you get? When ANC visits, when the coverage indicator is coming closer and closer to 0, the gap is getting closer to 1 because they add up. And what that means is that ANC coverage is extremely low, or by implication, the gap is extremely high. Then as the coverage indicator is becoming closer and closer to 1, it basically means that the gap is becoming 0. And that means coverage is being maximized and the gap is being minimized as much as possible. So for progressive realization, the whole idea is we want to ensure that countries maximize the index and minimize the gap. It's a dual here. Then I again generalize the index to account for quality. Again, I wouldn't go into these, but if you're interested, details are within the paper. There are a couple of axioms. As an economist, when you come up with a new index, you have to pass it through what we call properties to be able to assess whether the index really performs well or not. I put them here. I'm not going into them, but there is what they call symmetry or anonymity axiom. And there's a focus axiom, which is a very important one. Our focus should be on people we're interested in, and any other noise, we're not bothered. If a woman had 100 visits, it's irrelevant in this equation. Once you fix the policy objective, anything above the policy objective is a plus. It doesn't really change the model, or your outcome, etc. There are many others. So if you're interested, we can share the presentation for you to take a look at the axioms and the properties of the model. I know some of you might be interested in trying to go deep into this, but I will stop here and talk about the subgroup decomposition. And the subgroup composition, which is a very important, not necessarily property, but something of an nature, is that we can compute this index for mutually exclusive groups, like, for example, urban dwellers versus rural dwellers, people in the north versus people in the south, different geographic, so long as they are mutually exclusive. The poor, the rich, the uneducated, educated, so long as they are mutually exclusive groups, you can compute the index. And the beauty is that the weighted addition of all the indices will give you the original index. So you can get the original index as a weighted average of all the other indices for mutually exclusive groups. So which is a very important property there. So quickly, apply this to Uganda first as a single country. Then I applied it to about 35 countries in sub-Saharan Africa. And in terms of the application, I used the demographic and health and survey. Unfortunately, there are no quality indicators in that survey as yet. Hopefully, with time, that's going to happen. And the results show, again, that at least about 60.2% of pregnant women have had at least 4 ANC visits. But if you apply the new index, it comes up to about 0.854. It's not really percentage per se, but if you want to interpret it that way, it's okay, but it's not a percentage per se, but it ranges between 0 and 1. And you would see clearly that the gap is the summation of the gap and the index would definitely be equal to 1. Then if you quickly take a look at the way the index behaves by mutually exclusive groups, you would see that coverage is higher in urban areas compared to rural areas. It's higher amongst the wealthy compared to the poor, and it's also higher amongst those who are well educated compared to those with least education. Then I'm not sure whether I can see this, might be a little bit tiny. Apply this across 35 sub-Saharan African countries, and the results basically that there is some kind of correlation between having the 4+ ANC visits and the new index. And the reason is not far-fetched, because at the two tails, it usually happens at the two tails. If you have a country where almost 99% have had at least 4 ANC visits, then we don't expect any much difference between the two indices. Again, if you have about 99% with no visit at all, again, the two indices should kind of speak to themselves. But where the bulk of population would lie, or countries will lie, will be in the middle. And so you miss that. So the correlations exist, but mainly at the tails, and it's expected, basically. You would see that some countries had better new ranking, but poorer old ranking. I gave an example of Malawi, Rwanda, Tanzania, for example. And also some countries may have similar ANC for the previous visits, but different, very, very different new ranking. And that's because these two countries, a country might have made more progress than the other in terms of moving the poor to more visits. Nigeria and Senegal was an example. Some other countries may have a better ANC4 ranking, but if you move to the new one, it's very poor, which is very interesting to note. Benin Republic and Angola were pretty good examples. Now to conclude, is that we really, really need new measures. We really need new indices and indicators, especially in the context of the SDGs, to, as much as possible, assess equitable progress. We need to be able to account for the fact that populations are making progress gradually. No country makes, it's not a big bang. It's now or never. It's not a switch. There are kind of, either putting in funds or activities that are going on to move populations away from poverty, for example, or from illness, but it's not really a switch. And our indicators should, as much as possible, try to capture this as we move ahead. And progressive realization in this context is very important, given that many countries have kind of signed on to universal health coverage. And within universal health coverage, it's a gradual realization of the goal rather than an abrupt. There's no time you say, well, now I have started universal health coverage, but you kind of move gradually towards that goal. So in this example, which I've given, using ANC, having at least 4 ANC visits alone cannot be able to capture that progressive realization, because it's a switch. It's either you've had at least 4 ANC visits or not. So if you've had 3, if you had 2, you don't count, which is problematic, even though countries might be making significant progress, putting in a lot of money. And like we've seen earlier, those who tend to have attained at least 4 ANC visits are usually the rich. So if we continue to use old indicators, it means that we're leaving the poor behind, and we don't want that. We want to have indices that show how we're able to move those who are poor, those who are vulnerable, gradually away from vulnerability, which is very, very crucial, at least in the context of universal coverage and the SDGs. So in Africa, the proportion of women who've had at least 4 ANC visits can be very, very low in many, many, many countries. And again, the proportion can also be high in so many other countries. So countries like Nigeria, for example, you have about 50%. And if you move to countries like Ethiopia, it's 68%. And you could have countries with about 33%, etc., of women who've attained less than 4 ANC visits in this case. And you could have proportion in the range of 90s for countries like Sierra Leone, Ghana, for example, who've had at least 4 ANC visits. So at the two tails, you could find countries like that in Africa. So women with, like I said, fewer ANC visits come from poorer socioeconomic backgrounds. So it's important to keep them in mind. But the new index that are proposed provides an avenue for us to progressively realize the goal of universal health coverage and access to maternal health services using, for example, antenatal care as a proxy. And of course, there are many other issues to deal with, timing of visits, etc., which we couldn't account for in the model. But if you want to use the quality adjusted index, the quality adjusted index allows you to build into it timing, also the content of ANC received by women. That's what the generalized measure does. However, there are issues around how to measure quality. I'll leave that again. I'm sure a couple of people here might be used to measuring quality in different settings. And there's also a group that looks at quality of health systems as well. So kind of related issues. We know clearly that if you have ANC visits before delivery, of course, you're more likely to have a trained birth attendant at your birthing of your child. So there's some kind of correlation there. So if we can increase access to antenatal care coverage, then by implication, we're also increasing access to trained professionals who would assist in the birthing process for women. And we also want to ensure that these women have access to quality services. So with that, I want to thank you, and I'll be happy to take questions. I hope I'm doing well with time. Thank you very much.
John, this is great. No, you did perfectly with time, like right on the dot. I'm impressed. Thank you for sharing. To the folks who are attending this webinar, if you have any questions, there is the Q&A button at the very bottom. Please feel free to type them in. And while we're waiting for that, John, I had a couple of questions for you. One is, I am an ENT, so this question may come from complete ignorance, because the last time I thought about antenatal care was 20 years ago. Is the difference between moving a patient or moving a country or a group of a population from 0 ANC visits to 1, is that difference in outcomes and health the same as moving them from 3 visits to 4? And does your index actually account for that?
This is a very, very important, very, very important one there, Mark. Let me quickly start by saying what this index does is there are two different issues. The index in itself is divorced from health outcomes. Okay. The domain of trying to assess, it's a very interesting study. It's something that we could even try to look at in terms of whether but of course, science is there, and that's one of the reasons why WHO moves is pushing for having at least 4 NCVCs, because anything less than 4 or 8 in the current context is not optimal to provide good birthing experience. But unfortunately, this model cannot tell us whether moving women from 0 to 1, 1 to 2, or 2 to 3, which one leads to better health outcomes. But what it helps us to understand is that, which we know, is that the more ANC services you receive, the better it is for you as a pregnant woman. So that one is not disputed. But to be able to compute the marginal differences in terms of moving from 0 to 1 and moving from 1 to 2 or 1 to 3 is something that I didn't take a look at, but it's something that could be done different from this. But the model just kind of assumes, and I think it's safe to assume that having more visits is a better is better than not even having any visit at all. And it's from that premise that the index was developed. If that answers the question. Thanks.
Yeah, no, absolutely. It is a fascinating question, the sort of marginal utility, to be economically and dorky, of moving from 0 to 1 versus moving from 3 to 4. A couple of questions in the chat. So I have a question from Eric O'Flynn. He says, would love to hear any thoughts on what an index for surgical access could look like. The Lancet Commission modeling has a yes/no model for whether an individual has access to safe, affordable, timely surgery. Might we be missing some nuances with this measure?
Very, very, very interesting there. Thanks, Eric. In terms of access to surgery, well, not just surgery, let's just say access to health services. But I know you guys are focused on surgery, but I can as well just broaden it up to maybe there are people in the audience who might be coming to it from a different aspect. In terms of access to services, having a yes/no answer doesn't help, unfortunately. But it's not bad. It's not entirely bad. It's better than nothing. Okay, it's like that progressive realization thing I'm talking about. It's a first step, but there are nuances that will be missed by saying yes or no. Now the reason is, if you're focusing on access, access is multidimensional. Access could mean also acceptability. It could mean affordability. It could also mean whether something is available. So access is a multidimensional concept. But if you're looking at utilization, which some people see as an indicator of access, which is not the perfect indicator, but it's one of the indicators that you can use to measure access. If you're looking at utilization as an indication of access, then you can easily see the number of services that were utilized. But for you to measure access, yes or no, do you have access, yes, no, unfortunately, it's not very useful. But what is useful is there are many indicators. There's a Tanahashi framework. I'm sure some of you might have come across the Tanahashi framework of the 70s. Developed by Tanahashi when he was, I think, at the WHO. So now the issue is that you can therefore measure the different dimensions. You could have indicators for each dimension, and you find a way of taking an average. There are a couple of papers that have done that, looked at access to services, not just surgical, but looking at all the dimensions and finding a way to take an average, a weighted average of all the dimensions and put together. So the answer is yes, no, not very helpful, but you can, as much as possible, improve that. Yes, if that answers the question.
I want to follow up actually on that question. So within the Lancet's indicators for surgery, and yes, a lot of us here are focused on surgery, but within the Lancet's indicators for surgery, there is a surgical access, as Mr. O'Flynn was asking about, but there are other things such as sort of number of providers, density of providers, density of procedures. Would a similar index, financial risk, would a similar index be constructible for each of these indicators?
Possible. Now, to also highlight what this index can do is anything that gives you an idea of a policy target. The policy target is, for example, I don't know surgery that much, so I'm sorry, I'm kind of blank here, but let's imagine there's a policy target for surgery. And the target is that if you have X, whatever the condition is, you need 5 things done. I don't know what that is. I'm giving a rough example. You need 5 things done. Then you now know at least 5 things that must be done. Then you know there is a policy objective. So the measurement will now be who is doing at least 3, 4, 5, or more of those things. How do you then measure how you're moving towards getting that policy objective met? But if it's a yes/no question, then there's obviously no need for any index. I mean, it's automatically determined. It's either you have it or you don't have it. But if you're looking at many dimensions with yes/no across many dimensions, yes, then we can talk of many ways of aggregating it. There are many measures of central tendencies that we can use to find an average for that, but not this index. This index would not help in that regard. It will be more around aggregating dimensions per se, and not here.
Yeah, no, that makes a lot of sense. If we are looking at, say, there's a goal in the Lancet Commission of 20 to 40 surgical obstetric and anesthetic providers per 100,000 people in the population. But it seems like if we could split that up into sort of 5, 10, 20, 40, then an index like this could be constructed.
Correct. That's absolutely, and you don't even need to split it. The beauty of it, keep the numbers as they are, because the problem of splitting is by the time you aggregate, there's heterogeneity in the aggregation. So you want to keep every 1, 2, 3, just count them as they are. It will help. So
a question in the chat from Herbert Chikafu, 2 questions. One, is there scope or intention to adjust the quality component of this index to adjust parameters and meanings for the 4-visit limit? Women at higher risk or with maternal complications may require more than 4 visits, and thus the 4-visit limit may not be sufficient.
Very tricky question there. I skipped quickly through the measure using the quality, but let me quickly go there, given that, I have kind of ended my presentation when the presentation hasn't ended. Just to give you an idea of how that you can put in quality in the model. Okay, so if we go quickly to the quality adjusted indicator I gave earlier, you will notice that the way this model does it is that it allows you to measure the quality of each ANC service. Okay, now here we are. It allows you to measure the quality of each ANC service. So if you are able to basically measure the quality of every ANC service across whatever dimension it is, I don't have an answer. Any dimension you can choose as a quality measure, but what the model assumes is that you can scale the quality index between 0 and 1. 1 being perfect quality, 0 means the worst quality. So the worst quality is equal to no visits. It's either the worst quality is the same as no visit. So both of them having the worst possible quality it equates to 0. I mean, you say you've never visited him because it's nothing, doesn't really matter. So in this case, that's what the model assumes is between 0 and 1. Now, the part that is tricky, Herbert, is that for complicated pregnancies, there is no limit. Okay. Even clinically, I'm not a clinician, but I don't think clinically you can put a limit to the number of visits that you have with any complicated case, because by the fact that it is complicated in itself tells you it is complicated, and the number of visits depends on how the complications pan out. If you can control them, fine, then you have fewer visits. But if not, if it's something that the person needs to be monitored, even put in hospital for the duration of pregnancy, it has to be. So you cannot put a limit there. So what you could do in the case, what I've studied is that it's very few number of cases with complications in the entire population. But if you're interested in looking at that, the best thing to do is to isolate that and try and figure out whether women with complications, it's a different policy objective, women with complications, if you can identify that in a survey, have adequate utilization. But of course, the challenge is how then do you measure what is adequate, because each complication is different. By virtue of complication, you cannot have a uniform measure for complication. So I would really say you use qualitative measures or something to figure out that rather than quantitative. Unfortunately, that's one of the limits of quantitative measures. Then you talked again about, let me see. The first question, would it be correct to say that the index is helping in microscoping determinants of ANC utilization? I would say no, because the determinants of ANC utilization are what you're doing here is the realization. You're moving into the realm of realization. You're unable to capture unmet need, but the index gives an idea of the fact that there is unmet need. But how that unmet need arose, it's just an index. The index cannot tell us how the unmet need arose. However, it points us to the fact that there is a gap somewhere. Then the next stage is, let's figure out what are the determinants of ANC service utilization and why is there a gap in ANC utilization. So I think that's the best way to go, is to come to it in that manner.
Thank you, John. Mohammed Fahim Khan has his hand up. Should we see if we can get him to ask a question live?
Please do.
We haven't always been successful at getting the people to speak. The Zoom webinar platform isn't great with this.
Yeah.
Dr. Khan, if we can't get you to speak into the Zoom, if you don't mind typing your question into the Q&A box, we can answer it there. In the meantime, I had a question for you. Again, this is probably just a reflection of my unfamiliarity with this index. You showed, in your discussion of who is left behind, you showed that this index really kind of points out that the poor are being left behind. And there's a differential in coverage based on education, based on wealth quintile, based on urbanicity. Does the ANC4 index, has that been done across subgroups? And do you still see that in the ANC4 index, or is it just countrywide, yes, no?
Actually, the answer to that is that it's the ANC4 visit that even informed that in the first place. Many studies that we've done using the ANC4 visits show that poorer women tend to have, the proportion of women with at least 4 ANC visits is higher amongst the rich than the poor. Simple. So what that means is, therefore, that the poor tend to have fewer visits, by implication, fewer visits. So it means that amongst the poor, if there are policies to move them gradually to 4, they have been left behind. I mean, we don't know where they are until they reach 4 visits. But we know that many countries have made tremendous progress. Rwanda, for example, you find that Rwanda is not featuring as the top flyer if you use ANC4 visit. But if you use the new measure I've put in place, it pushes Rwanda really, really high above many other countries. Reason being that the country has made significant progress in moving people in rural, remote, mountainous areas to attain at least 2 or 3 ANC visits, but it's not captured if you use the 4+ visits. So why are we leaving them here? Why are we missing them? Why not bring them on board? Why not find an index that captures what happens to everyone, not just the rich that can get to at least 4 visits?
One last question for you, then I'm gonna let you go. I assume, can this be extended to ANC8? And if so, have you tried to do that? And does that inequity persist?
It can be extended to ANC8. The challenge there, which has kind of impeded my progress there, is the ANC8 is referring to contacts, not visits. So to be able to really do that, you need a specialized survey. Most of in short, I don't think any new one has done that. The DHS that we have are basically looking at visits. But the difference between visit and contact, I tried to talk about that briefly, was that with contact, you may not have come for ANC visit. You might have headache. I'm giving an example, and you visit your GP. But because you are pregnant, the GP would, of course, want to know more about the pregnancy, not just forget about the pregnancy and just deal with the headache. That is a contact. But if you look at the way the DHS collects data, it only asks in terms of ANC visit. The woman may not have recorded that as a visit per se, might be recorded elsewhere as visiting a GP. But how then do you link, which is something I'm struggling with, to link that visit to pregnancy? It's a challenge. But yes, it can be if you get a good survey, you can do that. But I've not been able to.
One final question from the Q&A box. This gets back to the outcomes question. Have you found a higher correlation with national maternal and neonatal mortality rates? A correlation between those and your index, is that correlation better than with ANC4? Very important question there. I would say I did the correlation. I did the correlation. The correlation I did, which is something I didn't talk about, I wish I had time to talk about it, was though there is correlation between having ANC 4 visits and neonatal deaths and maternal mortality, like I showed, it's important to realize that we shouldn't focus on that alone, because the pathway between antenatal care and maternal mortality is mediated by many, many factors, which I highlighted the social determinants of health earlier. So many women in many African countries die not necessarily because of ANC visit, but one, poor quality ANC visit, or cultural practices that put them in harm's way, basically, and their child's health as well. For example, I'll give a quick example. Though the correlation showed it was positive correlation, but it's not a perfect, and it's perfectly understandable. It's not a perfect correlation. One outstanding case is Sierra Leone. Sierra Leone has one of the highest, between Sierra Leone and Ghana, that's a competition, the highest proportion of pregnant women who've attained at least 4 ANC visits. But if you notice from the graph I showed earlier, Sierra Leone is one of the worst performing in terms of maternal mortality. And one would wonder, why is that so? Sierra Leone has the highest, one of the highest on the continent in terms of women who've had at least 4 ANC visits. But if you go into maternal mortality, again, is the worst, one of the worst performing countries. And the reason in the case of Sierra Leone was that the quality of ANC services is really a problem. Quality is really a problem. And that's the reason why it's not just important to look at the ANC visit, but to compute the quality adjusted index, which I gave. Unfortunately, I have not been able, it's my new project, but I've not been able to put out there in terms of quality adjusted indicators for ANC, likely because the current data architecture we have doesn't have very useful measures of quality. So we're working on that. We're trying to see, hopefully we get a good grant to be able to focus on one country, do an in-depth study to see how quality adjusted indicators vary from indicators that are not quality adjusted. I don't know whether that answers your question. Thanks. Another question, do you know in Sierra Leone and Ghana, what is the level of institutional delivery and postnatal care?
Yes, I don't know the exact proportion, but I can look that up for you. I mean, public statistics, you can easily pick that up. But very high, Ghana, for example, has one of the highest, well, South Africa is also included, proportion of pregnant women with who delivery at, when we talk, it's important to highlight this, having a trained birth attendant. It must not necessarily be a doctor. It can also be trained midwife, but proportion of women who've had at least birth attended by trained birth attendant, whether it's a doctor or nurse or whatever, is high in Ghana. In Sierra Leone, it's equally high, but it's not as high as Ghana. Okay, but Ghana beats Sierra Leone there. The only problem we found out in the case of Sierra Leone is that it's basically about quality. Quality in the sense that if you get to a health facility, the health facility is not properly equipped, and women even die in the process of giving birth. So even though they've had 4 NCVs, a lot of them die, and that's why the mortality is really high. Facilities are not prepared in many countries to deal with complications when they arise. That's where the major deaths come from, complications.
John, thank you. You've given a great presentation and endured a barrage of questions. Thank you for this. For the attendees, a little bit more housekeeping. So as Deirdre has just put in the chat, the recording for today will be available on our YouTube channel. She's reading my mind here. We will not be having grand rounds next month in July because RCSI is hosting the Times Higher Education Forum on the 7th and 8th of July. The Institute of Global Surgery is hosting 2 talks in that forum around collaborations and partnerships in global health and global surgery. So please feel free to attend. Please register at the link that she's put in. We are taking August off, so there will be no grand rounds in July or in August, and then we'll resume again in September. So keep an eye on your email, keep an eye on Twitter for links to that. And thank you all for being here.
Thank you for having me. Cheers. Bye-bye.
Thanks, John.
Bye.